Okay, we have me, George Rozakis. I'm an ophthalmologist, and Dr. Brian Bakke, who's a PhD in biochemistry. And the purpose of this presentation and dialogue between each of us is to talk about what you need to know about macular degeneration, and more precisely, what you need to know before having a phone call conversation with me about your macula. So I want you to listen to this conversation between me and Dr. Bakke about what you need to know about macular degeneration, and then we can schedule a call and speak with you about your exact situation. And so we can figure out if what we do can be of benefit to you. Let's get started. So I think one thing people need to know is that early diagnosis is fantastic if you can catch it early. And the only way to catch it early before any damage has occurred to the macula is to have a test called the ADAPT-DX test. Very few people have even heard of this test, but what the test does is it shines a bright light into the eye, and then you calculate how long it takes for the vision to recover. And if you take too long to recover, you're going to get macular degeneration. You think that's clear enough for people to understand?
I do. And I think, you and I have talked about this before, Dr. Razakis, over the years, that prevention is cure, right? That while we do have a solution to address both dry and wet macular degeneration, the overall goal is to prevent it from occurring to begin with.
Right.
Takes out some of the risk and damage and all of that can occur over time if you
Yeah, because if
develop
we
it.
can treat before the macula shows structural damage, that's as close to a cure as possible. And now our
Right.
understanding is that the biochemistry of the macula is not working properly. Otherwise, you would be able to recover from that bright light quickly. But if you don't recover fast enough, that means there's something wrong. And that's where we come in, where we want to fix the biochemistry. So like you just said, the closest we have to cure this disease is to catch it before it even starts to cause what we call structural damage, which we're going to get into in a second. So if a person out there has a family history of the disease and they want to know if they have the disease, we can refer them to doctors who have this special test called the ADAPT-DX. Need to know. Agreed?
Absolutely.
Yeah,
Yeah.
need to know. Okay, now the second need to know is that macular degeneration has real causes. In other words, people are told, oh, you're just getting older, just aging. And to us, that's not a smart way of thinking. There are real causes to the degeneration that occurs in the macula, such as oxidative damage, inflammation, problems with repairing DNA, hormonal deficiencies. There's a whole bunch of reasons why the cells in the macula are going to degenerate. And our mission is to treat these problems that occur in the macula. How else would you say that? Because I think that's a need to know.
It's absolutely a need to know. I think the aging process contributes to all of these, underlying root causes that you listed. Then there's also obviously uh, the dietary piece, which is obviously feeding into all of this. So it's lifestyle, it's diet, and then the natural changes that occur in the body over time that weakens the body and makes you more susceptible to some of these environmental and dietary exposures.
Yeah, and I think what they need to know, your good point, as they age, the cells lose some of their ability to protect themselves.
Right.
And when that happens, they're susceptible to damage. But there's ways to recover the ability for the cells to protect themselves. And that's one of our missions, is to turn on these defense capabilities of the cells so they can fight off oxidative stress, fight off inflammation, better repair DNA damage, and the like. So that's important for people to know. There's real reasons why this happens. And the next need to know is that blood testing can help reveal some of these causes. So that's why we're the only group in the country that does blood testing for macular degeneration, and we think that's crucial. What do you say to that?
It's absolutely crucial. So we assess at baseline 3 months and then every 6 months thereafter. And that allows us to, in a very personalized and comprehensive manner, continue to address any unmet needs that are identified and also deficiencies that exist. And this allows us to, over time, continue to get those levels closer and closer to what we would call optimized, which is where your body and cells are going to function at their best.
And a corollary to that statement is people need to know that when we put them on these programs, they improve the blood tests that we take and measure, and that improvement correlates with improvement in their general health, which is what you and I did before we even started the macula program. We were focused on general health, and then we found that we could actually help the macula as well. But the improvement in blood testing, the doing of blood testing, correlates perfectly with the fact that we can improve general health.
Absolutely. And the literature is full of correlations between these blood tests and some of the abnormal findings that we identify and the progression and risk of developing AMD.
I think people need to know that it can help kidney labs.
Absolutely. It can help kidney labs, joint pain, so general inflammation, mood, sleep, of course, anything related to aging, skin, hair health, and then obviously gut health as well. And the targeted cells in the eye, the what are called retinal pigment epithelial cells, RPE, also respond incredibly well to all of these interventions that we identify, where the deficiencies are identified through blood testing.
Yeah, so to us, it makes no sense why for 25 years, eye doctors have never done any blood testing for a blinding disease.
Right.
It just really almost disqualifies them as experts in the treatment of this disease at a fundamental biological level. And by the way, people should know that in the beginning, the studies that were done 25, 30 years ago were actually designed to disprove the value of vitamins. And that's a very hot topic when you really get down to it. Why would you want to disprove something? And then they accidentally proved that they had some value and did nothing to further pursue better strategies. See my point? I think people need to know that, and I'm a doctor as well. I'm an eye doctor. I'm an ophthalmologist. I mean, I for decades would tell people to take those simple vitamins and eat green leafy vegetables because I got tricked as well that was like the standard of care. That's the way to treat this disease. But what you and I discovered is that there's a lot more that can be done. And it took years before you and I came along and say, hey, wait a minute, let's apply a functional medicine approach to macular degeneration because we were seeing improvement. I think people need to know that there's a reason why the current standard of care never progressed. I think that to summarize it, how would you respond to that?
Yeah, I think that's a great point. And what we did was build on, even though it was inadequate, it was incomplete, that ARED solution. And we really just amplified it and said, okay, we're going to take each of these risk areas or risk factors that are present in the body and in the eye, and we're going to identify where we have a modifiable plan that we can put in place to address those risk factors. And it's going to be different for each person. So I think the comprehensive nature of our approach is really born out of the fact that the original solution was a one size fits all and very inadequate solution for the vast majority of people.
Yeah, yeah, it's crazy. So let's see, what do people need to know? Let me go through my list here. So what you and I did was we applied what we call functional medicine, which is what we were doing for the entire body to the eye. And by doing so, we discovered something. We discovered that it can help the macula. We saw it in a few people initially, then we did a study. So people need to know that when we applied this approach to dry macular degeneration, we found that we could stabilize vision and improve vision in 48% of patients with dry macular degeneration. That's a need to know. It's like we really can stabilize, and it's also possible to improve. Not in everybody, because people need to know that the longer they wait before getting treated, the more irreversible the damage becomes. So if you treat early, you have a better chance of stabilizing good, decent vision and get some vision back. if you treat too late, that return of vision is harder. That makes perfect sense, right? Because there's ongoing damage occurring to the eye. So early treatment is better than late treatment.
Yeah, beautifully stated, Dr. Azakis. And this, again, this comprehensive approach of functional medicine that involves testing on a personalized level for each person enables us to zero in on those specific risk factors for each individual. And that's going to allow us to not only have a more comprehensive solution, but also to get there much faster than we would if we were just guessing.
I think people need to know that when they have dry macular degeneration, many of them are going to have an accumulation of a substance that will drive the start of wet macular degeneration. This substance has a name, it's called VEGF, VEGF. I think people need to know that VEGF, vascular endothelial growth factor, is the stimulus for wet macular degeneration, which requires eye injections to remove fluid and bleeding from the eye. So I think people need to know that our approach, our macular program approach, can reduce the amount of VEGF in the eye. So think about it. If you have dry macular degeneration and you get put on a program that reduces this bad actor called VEGF, the chance of converting to wet disease is going to be less. So if you have dry macular degeneration, you need to know that if you want to minimize the conversion to wet macular, where you're going to need eye injections, you can be helped with our program. Dr. Baki, so such an important point. Can you echo that for me, please?
Absolutely. And I think, too, not only does it help mitigate the risk of progressing from dry to wet, once we are working with a wet condition, we know that it complements the injections to help lower VEGF even further. We've seen this over and over again from our clients that we're working with, where the retina specialist will start to reduce the frequency of injections and space them out over longer and longer periods of time. So that complementary approach is going to be far superior than using injections alone, which only delay the inevitable. And so that, again, from a prevention standpoint, what you need to know is that VEGF is a bad actor and it needs to be held in check at dry and obviously reduced in wet. And we've observed that in both types of AMD in the program.
Right. Beautiful. And what people need to know is that those injections to remove VEGF don't help the macula be healthier. They're focused on stopping leakage and bleeding, but they don't do anything to treat what got the patient to this point in the first place: oxidative stress, inflammation, and other insults to the biochemistry that's happening in the macula. So our program is not only helping reduce VEGF levels, but it's also making the macula healthier, which means better vision. So anybody who's getting injections, they might think that that's the only way to treat. In fact, you could almost argue, and it's a reasonable idea, I think people need to know this, is that the reason you're getting repeated eye injections is because they remove the VEGF, but then it reaccumulates, and you got to get injected again. Then so there's this constant removal and reaccumulation of VEGF. And what we would love to see happen is that our program stops the reaccumulation of VEGF as much as possible. I think people need to know that.
Yeah, and I think it's important that people also know that the injections themselves can also be detrimental to eye health over time. The more injections you have, the more likely you're going to develop, some complications associated with receiving those injections long term.
Yeah, no doubt. I mean, it's a non-trivial procedure. I mean, you inject the eye, which is an insult, then you inject some fluid with the medicine in it that can cause the pressure in the eye to go up, and that's traumatic. The injections are traumatic. They do help people. We're not saying they're bad. They are needed, but at the same time, if we can avoid overdoing it with injections or never needing injections, that's a great thing.
Right.
I think people need to know that. Okay, here's another one here that people need to know, and that again, we said it earlier, it's worth saying again. People need to know that time is critical. The longer you wait to get put on a program that goes after the underlying causes of macular degeneration, the longer you wait, the more irreversible the damage becomes. So earlier action is the best. As soon as you know you've got the disease, get treated so that you can avoid all the horror of vision loss, driving, hobbies, reading, etc.
I think that's a great point, Dr. Razakis. Not only is time critical on the treatment side, but we also know that time is a really important variable once you are following a protocol or a plan designed for you. We know the longer you follow it and the closer you follow the plan, to the standard, what we call compliance, the better your outcomes are going to be over time. And we know this. We see over the period of months and years that there's continued improvement in the stability of the eye, the health of the eye, and the opportunity for improving visual acuity.
Yeah, this gets us back to the study we ran. We talked about a 48% improvement in vision in dry macular. We had a 60% improvement in the management of wet macular degeneration. So people need to know that there's a good chance. And along with that is that, as you and I both know, with the passage of more and more time, people on the program either stay stable or slowly improve over time. Where we're very happy with the long-term results because we're over 5 years now in many cases of people that we're treating. And they just seem to reach a point where they just stabilize and their vision is better and they're not losing vision. Unless
Well,
they,
we've even had cases, Dr. Rozakis, I think this is an absolute need to know that some of our long-term clients have been told by their retina specialists that they don't even need to see them anymore,
right.
which is remarkable. So, and that's the goal.
Yeah. Yeah, that's a need to know for me too, that the retina doctors who look at these eyes, they comment and say, wow, your eyes look beautiful. Everything is stable. I don't need to see you again. And we love to hear that, obviously. Okay, now you need to know if you have macular degeneration, cataract surgery can worsen your macular degeneration. You need to know that. However, if a person has cataracts and they're on our program, we're not seeing this happen. We're not seeing damage to the macula. We're not seeing people lose vision after cataract surgery. So if I had cataracts and macular degeneration, I would want to be treated before my cataract surgery. I think that's a need to know because you don't want to get surprised by having cataract surgery and the next thing you know, your vision is worse. That's a need to know. What should we say about diabetics and macular degeneration?
So we know that many of our clients come to us with diabetes. There are others that are perhaps unaware that they're at risk, where they're in that kind of in between pre-diabetic state. And that's where blood testing really comes in, Dr. Razakis, where we can assess blood sugar parameters that are going to give us an indication as to how well or not people's metabolic function is being maintained. And we know that the worse off you are, the further along in the progression of towards diabetes or in full-blown diabetes, that your risk of progressing AMD increases significantly.
Yeah, diabetes can worsen macular degeneration. That's a need to know. But our program supports the diabetic patient, supports their macula, supports their body. So if you have
Right.
diabetes and macular, then the program has two values for you. And I think people need to know, and we didn't talk about this yet, but we should focus on this for the moment, that our program is designed to improve the health of cells in the macula. Cells. We're trying to make the cells healthy. Now, the cells that become damaged in macular degeneration are what you said earlier, the retinal pigment epithelial cells. Now, there's a different type of cell that becomes damaged in diabetes, and we can make those cells healthy. So we think cellulars, like what cell is not working properly that could be causing the vision loss and problems. So we can help the cells in diabetes. We can help the cells that go sick or become sick in macular degeneration. But the bottom line is if you have diabetes and macular or just diabetes alone, and if it's affecting your macula, you need to know that our macular program can help a lot, actually. Okay, what else do people need to know? I think we've talked about this, and I'll say, let's talk about it in a little more detail, that the programs that we put together are not limited to the eye. You need to know that when we make these programs, we're also trying to improve general health as well. Do you want to add to that, Dr. Baki?
Yeah, you mentioned this earlier, Dr. Razakis, and it's a great point that's worth repeating, is that while we are targeting those RPE cells in the eye, we know that other cells throughout the body, as you mentioned, the beta cells that are associated with blood sugar regulation, or kidney cells, uh, when you talked about kidney function improvement, all of the cells in your body are going to require some of these key nutrients and are affected by many of the same risk factors that we identify in the blood testing. So while we are focusing on the eye, the effects end up propagating throughout the body, where you get a whole body effect, where all of the cells in the body can benefit from our approach.
So that is what we do. This is so-called anti-aging medicine, functional medicine, integrative medicine. It's how can we get the body to a point where it starts to fix itself and help itself because of the problems that occur with the aging process. So a lot of these are reversible. For example, hormonal decline, very common. You know, we see that, we measure it in the blood and we treat it, and people get an improvement in their general health and in their macular health. And we do that across the spectrum for hormones, for oxidation, for inflammation, and nutrition, and all of these come together, because that's the success of our program, is that we don't do one thing. We attack the problem of the disease in a multitude of manners to find and get the result we're all looking for, which either stability or improvement.
Beautifully stated.
Okay, now let's talk about complementary therapies, because people out there today are now hearing about this new red light therapy idea. And, you know, we're in favor of anything that works, right? Anything that works. So red light therapy is interesting. When I looked at the data for red light therapy, I'm not seeing any significant improvement in vision. Their statistics don't show that. They show just a tiny bit of improvement. So they're really trying to help with stability, in my mind. If I was going to have red light therapy, it would be, my expectation would be that it's going to help me, hopefully help me, not progress. But one of my issues with red light therapy is that people didn't get macular degeneration because their eyes have not received enough red light for the past 25 years. See my point? It's like, well, you know, I'm gonna treat your problem. I'm gonna put red light therapy into your eye. Like, oh, is that what I've been missing all these years? Is, you know, red light?
Right. Nobody's been diagnosed with a red light deficiency.
Yeah. So I have macular degeneration because I have a red light deficiency. We're going to put red light in there and we're going to fix that problem. You know, so look, I don't want to be overly negative, but I think it's very expensive, first of all, red light therapy. And I think everybody should be on our program because we attack the problem at its root cause. I mean, what caused the problem was oxidative stress, problems with mitochondria, problems with hormones, problems with inflammation. You know, that's what caused the problem. We're treating the root cause of macular degeneration. And, you know, red light therapy comes along and says, hey, we can help the mitochondria work better, the energy producing part of your cells work better. Is that really true? Okay, I hope so. Does it really work? I don't know. You know, we hope that it can help, but it's very expensive. And right now we're not feeling the value yet. But if it does create value, we're happy for them, right? How else can we position ourselves relative to red light therapy?
Well, I think great points, Dr. Razakis. It's also, there's a big difference between some of the commercial red light therapy options that are for in-home applications versus the red light therapy that is available in clinic, which you're referencing, that is very expensive. And there's quite a bit of a difference between the effect of those two different types of approaches. And so it requires like 25 or 26 office visits. It's, in the many thousands of dollars for red light therapy. And to your point, the return on that investment is that you get 4 or 5 letters on a single line on the eye chart, which is not terribly impressive. I think you famously said it at one time, you could almost coax somebody into seeing a few extra letters on the same line. It's not, there's not a big justification here for pursuing this as a complementary modality of care. Although, as you noted, we're not against it. It's just not as cost effective as certainly as our program and this approach that we have.
Yeah. And then by the way, there might have been 5 letters of improvement, but in the control group, they had 3 letters of improvement.
Right.
We're talking.
So yeah, that's kind of your point, right? About
I don't want to make light of it because I know the people who are involved in red light therapy. I respect them. I wish them the best. But if it were me, I'd get on the macular program, get my blood tested, get a program, take the program. We have more follow-up, or as much follow-up, or probably more follow-up than the red light therapy people have. They're in about 2 years. We're further down the road.
right.
I don't know. It just seems that if red light therapy is going to work, it should come on top of or after the macular program. And
Right.
and we look forward to seeing our patients try red light therapy so that we can learn from them if it helped them at all. So we're all about whatever works, and I think that's fair.
I think the important takeaway here is, what do they need to know? It's quite costly. The early results are that it's somewhat but minimally effective. And we don't have anything against it. So if it's something that you want to pursue in conjunction with the program, then there's no reason that you shouldn't be able to do that. They would work in a complementary fashion, much like injections. I think, injections are helpful, but they're not a solution. They're not going to give you the long-term stability and outcomes that you would achieve by doing what we do.
Let's talk about geographic atrophy. This is an interesting subject. Geographic atrophy. So that's a disease where the retina is atrophic, it's thinning, it's degenerating in localized areas. And there's a push right now to give eye injections to stop the enlargement of these areas, these geographic areas, from enlarging. Now, in all the years we've been working, I think we're not seeing progression of geographic atrophy. And so our suspicion and belief is that our program is helping stop geographic atrophy, which would reduce their need for eye injections. And so if you have geographic atrophy and your retina doctor is telling you to start eye injections, you might go ahead and do that. That's fine. Or you could do the macular program and watch and wait and see if the geographic atrophy gets bigger or not. If it stays the same, then you've avoided eye injections, which is a good thing, because sometimes those eye injections can worsen the macula, can turn a dry macula to a wet macula. So, we're not against these eye injections. We just wonder if they're not necessary. The beauty of the situation is that geographic atrophy will progress slowly. It doesn't happen quickly. So if you have repeated eye examinations, you can check to see if it's bigger or not. If it really is getting bigger, then you can start the eye injections. But we're not seeing many people progress with their geographic atrophy on our program. That's a need to know for that subset of people who are dealing with geographic atrophy. So if you have geographic atrophy, you can go ahead and get eye injections if you want, or you can try our program and have your doctor watch you closely. And if you're not progressing, you don't need eye injections. Is that clear enough?
Yeah, that's beautifully stated, Dr. Razakis.
Yeah, that's a need to know. That's a need to
Yeah,
know.
agree.
Now, another need to know, and then we're almost at the end here, is there are other diseases of the macula that exist, which are not macular degeneration. But there's a different type of degeneration, like a disease called retinitis pigmentosa, or other diseases that are inherited, where the cells in the macula are abnormal and they die off, not from aging, but from a genetic error. So our position on that is that we can help those people progress less quickly on our program. We believe that because we've had people with these inherited diseases like retinitis pigmentosa stabilize or improve. And so the need to know there is that if you, regardless of what retinal degeneration problem you have, we should talk because we might be able to help you as well. It's not that we're not just limited to macular degeneration. What else? What have we missed? Is there any other need to knows are there?
I think we've that's a comprehensive tour de force of kind of the history of the program, our approach, our mindset, how we think about it, the outcomes, the studies. Um, it's highly effective.
I
It's a
think
highly
people need
effective.
to know, let's not forget that you have a PhD in biochemistry and a master's degree in nutrition. And you've applied all of that brain power to the macula over the past decade and more. I'm an ophthalmologist, and I've been involved in functional medicine work for many years, decades. That's something else people need to know. It's like, who are we? I think people need to know that, we went from treating the body and then discovering that it can help the eye. So we didn't come out of the gate trying to treat the eye. We sort of just discovered that the eye can be benefited, and we just we followed the trail, so to speak, like a good hound dog, and came upon the macula program. So we pursued it, and luckily our decision to do that turned out to be a good one because we continue to see these good results. So that's a need to know.
I think that's the other point that's really important that everyone needs to know is what you just said, and that is that you're a ophthalmologist in the classical sense, but very different in the fact that you've been practicing functional medicine for many decades now, and that you and I have been working together for 2 decades. And that combination of skill sets, background expertise, clinical experience is really what ends up producing these end results, which is not what you find in any practice anywhere, and why they don't do blood testing. It's not easy for the typical classically trained eye professional to leverage all of this knowledge, all of the testing into the clinic and to put together personalized plans for each of their clients. That's why we exist. That's the space we live in.
Yeah.
And that's a really important need to know is that the team that we are a part of is and that we make up is really unique in the eye space. And I think our results speak to that, and really demonstrate how powerful it is.
See, ophthalmology tiptoed into functional medicine when they created the ARADS formulation, the simple vitamins that people take. And then they really were out of their league to do that. They should not have done that. To sit down and say, hey, we're eye doctors and we're going to create a vitamin supplement for the macula. They're just not trained. They don't know. You can't talk
Right.
to an ophthalmologist about hormones and their effects on the eye or the things that we think about: methylation, oxidative stress, nutraceuticals, nutrition. They can't do it. It's impossible. So they just give out those simple vitamins and call it a day. And that was the mistake that resulted in an epidemic of vision loss. And it's a problem. And then even now today, here we are, and now we're going now the field of ophthalmology, God bless them, are going after red light therapy. It's like, something simple, expensive, something they can do, shine a light into the back of the eye. It's like, come on, guys. Let's treat this disease as what it is. It's a cellular degenerative disease with multiple possible causes that can be addressed with a functional medicine approach based on blood work. And that's just common sense. So, yeah, I mean, we hooked up together and found out that it can benefit the macula. And we're very happy about that. It's exciting. Nothing excites me more than getting a patient chart telling me the same thing over and over again. Went to my doctor, things are stable, doing okay. I'm so glad I started this program. I just wish we can catch people earlier in the process. I think that's the other need to know here, is that people make the mistake of waiting until they have vision loss before they act. And they're harder to treat when they start to become wet or lose vision. It's just harder. It's more work. So if they can only be, told that it's almost an emergency now, should we call it an emergency? No, but it's a significant event. If you're told you've got drusen and changes in your macula, fix it, do something about it. Because the current standard of care with vitamins and green leafy vegetables is not stopping the disease. They need to know that.
Dr. Rozakis, you've used an analogy of a house on fire, right? And no one would, if they saw a small fire start with a little bit of smoke coming, wait until it progresses. You would put it out as quickly as possible. And I think that corollary with the eye is important, because by the time you have a full-on inferno, it's going to be too late, and you don't want to wait until you have irreversible damage. That's really the point here, is that we want to make sure that you're getting that fire put out, or those fires put out in your eye and your body, before it progresses to something that can't be either slowed down or stopped or reversed.
That's perfectly stated. No, you're right. I do use that analogy a lot. It's like a house on fire. So what do you do when you see a little bit of smoke, coming out of the kitchen?
Yeah.
Just
It's and I think
put it
the
out.
eye, you can't live without your eyes. I mean, your quality of life isn't there. I mean, we all rely on our vision for everything, and obviously connecting with loved ones and traveling and seeing this beautiful world that we live in. To lose that is just unconscionable. I can't imagine losing my sight. And we don't want anybody that's watching this to have to go through that either. Even if it's to lose some level of functionality, you don't want to have that visual decline. Even if you still have sight, you want to preserve as much as possible.
Yeah, and that's an important point. That's what people need to know. When we evaluate people for the first time, it's like that's like the big question: do you have enough vision that's worth attempting to preserve? I mean, or is it too late? I mean, have you gone down to count fingers where you can't barely count fingers a foot away from you? If your macula is burnt out and gone, if that house is burnt to the ground, we can't rebuild a house. And so that's like the number one question, is like, is there enough vision here that's worth preserving? Many times people come to us with really bad vision in one eye, and that eye is pretty much lost, but the other eye is still hanging in there. So I tell them, look, we'll do our best with this eye here, but we got to make sure this eye doesn't go down the same road, because that would be catastrophic. And some people get it. But but it's important to realize that something more can be done. At least, get your blood tested, figure out what's wrong with your body that could be affecting your eyes, and let's put together a plan. And that's what we did.
Yeah, I think too, Dr. Rozakis, it's important to note that we both have family histories, your mother, my father, with macular degeneration. Neither of us have any indication that we're on the path to developing it. And it's because we're also following the program and in that prevention model. We're going to ensure that we don't get to the point where we start to slip, and we have some of those early indications that AMD is developing. And so we are the prototype for the prevention model, family history.
Exactly.
And,
My mom had
we-
macular. She was our first patient. We
yeah,
put her on an anti-aging program to help her age more gracefully, and then she was the one that stopped progressing. And I started to realize that when I examined her eyes. I said, hey, wait a minute, she's not getting worse. And then she continued to not get worse out to 15 years before she passed away at like 90. And
yeah,
she was an eye opener, that's for sure. So it makes sense if I'm dealing with macular. So the take home message that was need to know, I got macular, fix it, treat it early, treat it before you lose vision, because you don't want to lose vision. Not cool. All right. What else? Anything else we're missing? Need to know?
no, that was a tour de force.
Yeah. So what we do next is, for anyone listening to this, the next step is book a call so we can talk to you about your exact situation and tell you, what's involved to get you into the program. Hopefully you've got a little bit of macular degeneration, that those cases are easier. It's less expensive to treat those types of patients as well, which is good for you to know. But we like to talk to you on the phone to understand your situation. And then we'll tell you if we think we can help. So the next step, after seeing this video, hopefully this video is gonna educate you enough so that when you get on the call with us, you have most of your questions answered. That's why we put this video together, because this is what you need to know going into the call with me to talk about your eyes and your situation. So hopefully this presentation between me and Dr. Baki was helpful to prepare you for the call. And we look forward to speaking with you.